starting up a new project. It's kind of getting well underway. We haven't treated any patients yet, but it's well underway. Cryoneurolysis. Cryoneurolysis is applying cold temperatures to nerves to cause a type of temporary nerve dysfunction. You actually damage the nerve in a really unique way that's totally reversible. You essentially cause some type of damage. And so why would you want to do that? When we do nerve blocks, we get about 12 to 18 hours from a single shot, if we're lucky, sometimes less. You guys know that. If we put a catheter, as long as the catheter stays in, it can work, but we're limited by infection, 5, 6, 7 days. Same with an epidural, 5, 6, 7 days, infection becomes the issue. And patients are attached to now a pump and tubing, so it's kind of a hassle. Cryoneurolysis can last for months. So that has a positive and a negative. Some people don't like being numb. And so if I do something and you're numb for months, you're gonna hate me. So we have a kind of a solution or a strategy to try to figure out those people who don't want to be numb. And if we do it to a motor nerve, we're gonna shut that motor nerve down for 2 to 3 months. So we're almost never gonna do that. Maybe an amputation. There's some real narrow indications for doing motor nerves, but sensory nerves where you're gonna shut off the pain, this can be very helpful, especially for conditions like rib fractures, where the pain typically lasts 6 to 8 weeks or more. So the big problem with rib fractures is you need to cough, breathe, move, and sleep if you're gonna get better. And it hurts every time you cough, breathe, move, and try to sleep. Classically, they say people wake up 17 times a night when you do studies, and you ask people to fill up a diary log, because every time you turn, which we do all the time in our sleep, you now re-stress those structures. And so it puts them at risk for respiratory complications. We know that pneumonias, hypoventilation, they need oxygen, they go to ICU, they get positive pressure ventilation or non-invasive ventilation. We give them opioids as our kind of first-line therapy, which can work for some people, depending, but often with opioids, you're comfortable when you don't move, which is not this. We need you to be able to move comfortably. So opioids are not enough for a lot of people with very severe injuries. If you're not getting out of bed, DVT and pulmonary embolism, agitation, confusion, all of the risk factors and complications that come with opioids. So is there something more that we can do? It's more of what I just said, but basically it can be, if you have 4 or more rib fractures and you're over 50 years of age with underlying lung disease, you can have a 30% mortality just from your rib fractures, assuming no other injuries. And you can kind of imagine why. You're in ICU now, all those things start to stack up. 8 or more rib fractures, and we do see that. It's often the elderly, like young people, we get a few rib fractures, or if it's a major accident, you get, you're in a high-speed highway accident, unrestrained loss, but typically it's more the elderly fall, kicked by a horse, fall off a horse, crushed by a horse. That seems to be very common here. So hurts a lot, especially on the side. And we do multimodal pain, of course. We do Tylenol, we do NSAIDs, and nerve blocks. Nerve blocks have helped a lot, but as I was saying, you only get a few hours from it. You get 12 hours, or you get, if I leave the catheter in, you get a few days. But that's about it. And then we send you to the ward, maybe we send you home. But clearly, a lot of those people do come back to emerge. When you talk to the emerge docs, they're back for opioids or for some help. And there's a group of them that go on to chronic pain. The ribs don't heal quite right. There's excess movement. You have kind of like a subluxation where the cartilage and the rib come together. And so some of those folks suffer for 6 to 12 months or more. We'd like to do something about that. So as I talked about already, multimodal, respiratory depression, I didn't mention that. So you're not gonna cough, you're not gonna take deep breaths because you're kind of sleepy. And then issues with dependency and withdrawal, right? So you need lots of doses of opioids, particularly if you're young. You may get some tolerance, it may be hard coming off of them. We may not do the best job in getting you off of them. So nerve blocks, we have lots of choices: epidurals, paravertebrals, rectospinal. There's a ton of different ones that we can do depending on where your ribs are fractured, if you're on blood thinners, what your infectious risk is. But basically single shot, 6 to 12, maybe 5 to 7 with a catheter or an epidural. So cryo, like this I told you already, cryo cold, neuro nerve, lysis is to injure, damage, or cause dysfunction. And so the intercostal nerves run under the ribs from coming off the back towards the front. And they run just in a bundle with an artery and a vein. And so we can actually see them on ultrasound. And ultrasound is what's made this possible. So step back a step. Cryoneurolysis has been around since the 50s. Surgeons were doing it after thoracotomies because the ribs were sitting right there. So they could see the nerves and they could apply cold directly to them. And it actually worked pretty well. But about a third of those patients would get ongoing nerve injury. So it wasn't temporary. It was a permanent thing. They might have neuropathy or areas of pain after everything was said and done. Surgeons didn't like the hassle, so that kind of went away for a little bit. It stayed as part of chronic pain treatments, and it actually got advanced. They had more and more sophisticated tools to do this, but it was still mostly done either blind, like a lot of our nerve blocks, or with nerve stimulation, or just kind of anatomical, like, well, it should be under the rib, so if I just walk off the rib, maybe I'll find it. For this to work really well, the size of the ice ball you make is only about 1 centimeter, and it needs to be on the nerve. So as ultrasound got better and we could see these structures, it opened up the door to do more of these things on smaller and smaller nerves. And you've seen now we have excellent ultrasounds. We can find intercostal nerves, we can find the pulsations of the artery and know that we're right there. The other thing that happened was it got miniaturized. So this is what it looks like.
Oh, wow.
It's a handheld device. It can go to the patient's bedside. This
Oh,
part
wow.
comes off. It's powered by nitrous oxide.
Oh, nice.
So there's a little cylinder that goes inside of here, and this has 5 treatments in it. Typically you need to treat 5 to 10 per patient. And then there's a needle that's blunt. It doesn't open. I won't open it because this is $700. So that's the cost. That's the part we're going to get back to it. It's blunt though, so the nitrous oxide is not injected into the person. What it has is it has a tiny inner needle. You can't really see it. A tiny inner needle that goes down and opens to an outer closed needle that has larger space. So when the device is fired, it sends a controlled jet of nitrous oxide down this tiny inner needle. At the tip, it expands. In doing that, it drops the temperature down to about minus 88 Celsius. Just really local though, right at the tip of that needle. And then the nitrous oxide is vented back out to the room essentially. And it's trace amounts. It's not very much because you can see how tiny this needle is. And the catheter inside it is actually a glass fiber that's a hair. I went to the factory where they make them. It's pretty wild how they do all this. And there's microchips and all kinds of other. That's why it's expensive. Because it needs to do a cycle. So it's all timed out as to how long that ice ball exists before it then thaws. So we don't leave anything permanent in the body and we don't inject anything into the body. Forming that ice ball at that minus 88 turns out to be the kind of really close to the perfect temperature. Minus 40 to minus 100 causes a temporary dysfunction of the nerve. If you go above minus 100, you start doing permanent injury, which we don't want. And it's super localized, so blood vessels and things nearby are a heat sink. So the ice ball, if you're near a blood vessel, you get a very, very tiny ice ball that you need to be on the nerve. And that's the kind of the downside of this too, is you have to be right on the nerve. Unlike our nerve blocks where we can kind of be close and flood the field with local anesthetic, here it's a teeny, teeny treatment. So it's a little bit of a dart or a sniper kind of thing going on.
You have to be perfect. It sounds like Scott.
In fact, you have to kind of treat, usually nerves, you have to treat them multiple times to be sure. The one downside of this is if you partially treat a nerve, that can cause a kind of inflammatory nerve pain that responds to further treatment. But you want to do it right the first time. So that's the key with this, is we need to be very, very precise. There's a classification for types of nerve injury. You don't have to know this, but this is second degree. It's totally reversible nerve injury. But injury sounds bad, I understand, but it's what it is. We're going to cause a breakdown in the axon and its outer covering, but there's a skeleton, there's fascia and lining that covers all of our nerves. So perineurium, epineurium, and endoneurium are all intact. They're like the scaffold. They'd be the studs in your house. We're taking off the drywall is going to grow back, but we leave all of that in place. And so the cold at around that temperature doesn't damage that, but it shuts down nerve conduction until the nerve can essentially re-drywall, regrow. And once it does that, you get normal sensation again. And this has been pretty well shown. There's a group in Victoria that's doing this exact same thing, not for pain, but for muscle spasticity. So you can do this exact same thing to the nerves inside of muscles that are spastic, folks who've had traumatic head injury, anoxic brain injury, and you can make the muscles relax such that they're not completely paralyzed, but they're more relaxed. Now they can do physio. They can get people who are in a flex position able to be straight, sit up in a chair.
Wow.
So I went there and trained with them. It's amazing, but I bring them up because they do thousands a year. They've published case series of like 300 with like 1% or less complication rate. Like it's a very high volume center in which they're doing this, and it's kind of got a good track record of safety. There's a bunch of papers that have been done looking just at rib fractures, so I've got them in this presentation. This also has great utility in knee pain, shoulder pain, amputations, foot and ankle, so there's a lot of other use cases. And so alongside of my rib fracture project, Dr. Bujo-Murray and I are working on one for knees.
Right.
So we'll be treating, we're still sorting it out. So people have done non-operative knees, folks who really aren't good candidates for surgery, or people who want to wait. They want to try to push their surgery. Maybe you get treatment and then you do physio, you try some different medications, you try weight loss, you do a few other things. So maybe you avoid a knee replacement, but more likely you just push it down the road a bit. But it could potentially allow you to get in better shape for your knee surgery, quit smoking, change your medications, get your diabetes under control. So it has a potential for that group. Then there's the group who you think will be chronic pain after knee surgery. So they're on opioids. They've had chronic pain conditions from, CRPS, from say a wrist fracture. You could treat those folks, and there are papers that have done that to show that they need less opioids and they do better after surgery because you're using a non-opioid approach, using this for months. Then the third group are those who've had a knee replacement and they've got that chronic pain, and that can be 20 to 30% of knees where people are unhappy with their outcome. We see them back, we do manipulations under anesthesia, we maybe do an epidural or a nerve block. So this may be a treatment, a way to try to rescue those folks. It's not a cure-all, but there's a lot of indications for it, and so I'm kind of excited to bring it here. This was a nice paper that looked at doing this and comparing it to a single shot block for rib fractures, and I just threw this up to show some of the things here. So we get results immediately. This worked within hours. Patient's different. The big one was their breathing. Their ability to do incentive spirometry strongly predicts their pulmonary complication rate, and so with a single shot nerve block, they were able to push out about 1.3 liters, having had cryo done 2.2 liters.
Wow.
It's substantially more. That's a meaningful difference. And so they're breathing better. Their opioid use decreases. From the folks that are doing this on the coast, Vancouver, Victoria, I think there's a guy in Prince George about to start doing it. They're seeing they cut their opioids overnight by 50%. Whatever they were on pre-cryo, they go by half the next day, and with good pain control. And they're in the 1 month, nighttime awakening.
Look at the oxygen.
That's crazy. Yeah.
Right?
Yeah.
So this is such a really exciting thing, and it's something that's very doable for us here. It doesn't require, I don't need fluoro time, we're gonna use our ultrasound, we're gonna do a lot of them over in the block area. And I don't think, it's not gonna be a lot of these to begin with, it's just gonna be me, but there's no reason my regionally skilled colleagues can't pick this up as well.
Right.
I would send them off to go train with the guys in Victoria. So, who shouldn't we do this for? Obviously people who don't consent or uninformed, who don't understand what's involved. If there's local infection, that's a concern, so you don't want to put needles through infected tissue, makes sense. If you have a bleeding condition, we need to be a little bit, make a judgment call about this. So depending on how deep it is and where we're putting the needle, sometimes we will do blocks on anticoagulation, sometimes we won't, it sort of depends. There are some rare cold conditions, something called cryoglobulinemia and cold urticaria, where people have aberrant responses to cold. It's suggested that you avoid that in those folks, so there's not actually any case reports or anything to suggest why. And then Raynaud's is considered a relative contraindication, and essentially what the specialists tell me is they don't do the hands and feet if someone has Raynaud's, but there's no contraindication to doing it for the trunk or torso or even the knees. There can be some local effects, so you can get some discoloration or depigmentation at the skin. You can get hair loss, usually very, very small things. There can be some prolonged numbness, which is what we're looking for here, and motor block if you block a motor nerve. So the goal is to not do that unless the risk-benefit favors that, like in, say, an amputation. This is what we just generally do for rib fractures anyways with NSAIDs, opioids. There's a rib fracture score that I didn't show you, but basically trying to identify the people that are at high risk, because not everybody with rib fractures needs this or needs our attention, and generally we don't see them. But if their rib fracture score is high enough, if their age is high enough, or if their underlying comorbidities, bad COPD, etc., we might be involved in those folks. That's my silly little dog. So that's the kind of the quick and dirty. I'm happy to answer any questions you guys have. Or
The big thing is, so how long is this going to take compared to your other blocks?
yes, it is going to take longer. This is
'Cause you
probably
have
an
to be-
hour.
okay.
Yeah, this is probably an hour because
okay.
you're going to treat multiple times. It depends how many rib fractures. So if we're doing, say, 3 ribs, we're going to treat 5 levels. We're going to treat 1 level above and
Okay.
below, because your body, there's a little bit of cross innervation. So you've got to treat all the fractured levels plus a level above and below. Probably 2 treatments each nerve in the case of the rib fracture nerves. So people that are doing it about an hour.
Right.
So it's a little
It's
bit of a thing.
time-consuming for you
It
guys.
is. Yeah, that's right. So I'm going to do it probably on a PSS day, a day like today where I'm not in until 5, a day where I have the time. Like it's just not something I can rush.
Right.
Yeah.
We'd set up over there. For rib fractures, the best thing to do is to get them either lateral or prone. We want to go as far to the back as we can to do this, just because there's a nerve, there's a branch of the nerve that comes off in the axilla. We don't want to miss that. So we want to catch everybody. And often the fractures themselves are kind of posterior, so it's good to get as far to the back as you can with this. Blocking in the front for posterior fractures doesn't work, so you got to get back there. So that can be one of the things. You got to get them on their side. If someone is vented or on pressors or needs a lot of support, we're either not going to do this, or I'll go to the ICU and do it. That's the other thing. Is that this is a very portable thing. Our ultrasound's portable, as you see. this is what I need.
Yeah,
So that's very portable.
That's cool.
We have enough funding to do 25 of them as part of our pilot.
Oh.
Orthopedics has funding that they're just sort of figuring out to do some for the knees, and it's about $700. That's the consumables. It's 2 of these guys and 1 of these.
And what you save?
Oh yeah, so we pay
Months,
rib
right?
fractures
Yeah.
because we know if we get someone out of ICU, if we do this, the
huge.
next day they leave the unit, we've
Right
saved
there.
$1,000, $2,000.
Yeah.
Instantly,
right?
right,
So we
yep.
paid for it, done.
Yep.
And then all these other indications, some centers have found money under different kinds of pools, either government innovation projects. There are places where they ask people to pay, so they say, okay, it's gonna be $700 for
Yeah,
3 to
pay
6 months
that
of
in a
pain relief.
heartbeat.
There
Oh,
are
yeah,
people who will
yeah.
pay,
Yeah.
right? And there are people
Oh,
who
yeah.
can't pay, and you find ways to look after.
Yep.
So,
Right.
so right now it's just pilot. We're gonna do it. We're gonna study those folks. We're gonna interview them.
Right on.
We're gonna talk to them, find out what their experience was like. We're gonna gather some of those breathing data, pain score data, opioid data. In the case of the knees, it's gonna be stuff about walking and how well you flex. JVM says he'll see them in his office and do some of those testing.
Okay.
And we'll call them 2 months, 3 months,
Right.
4 months, figure out how long is it lasting for them. Is there any tweaks to what we're doing that we need to do? Generally, it's very well tolerated. People don't need sedation for this. They get a little local in the skin. I mentioned something, so the numbness. There's certain people that don't like being numb. It really bugs them, and they actually will sometimes say, look, I wish I had the pain. So what we do for those folks, or for everyone, is you do a diagnostic block with lidocaine. So you block the nerve with a very small amount, right where you're gonna do the cryo, and you wait, and you see, is that better?
Oh, okay.
Is that worse?
Right.
How would you feel if that was 2
Like
to
a
3
little
months?
test,
Are you okay?
yeah.
And
Yeah,
if they're
yeah.
like, yeah, hey, I hate this. Okay, you know,
Oh,
no problem.
okay.
You're not, so we don't go on to cryo. So but
Right.
it's a very small number. Most
Right.
people will trade pain for
Little
even some
numb.
numbness, knowing that it's a couple of months.
Right.
Yeah, so that's the trick, is you do a diagnostic block first, wait a little bit, make sure patient's happy, and it addresses their pain. If you do this and their pain's no better, then okay, well, cryo's not different than a nerve block, it just lasts longer.
Right. Right.
But again, no tubing left in the body, no epidural and pumps
Yeah,
and alarms and all of that, and people can go home. They don't
That's
have to even go home with a bomb.
incredible,
They just
yeah.
go home.
Yep.
So we know that other injuries often happen too. So they got femur fractures, tibia
Right.
fractures. So we're not gonna. I can't magically change all that.
Right.
But the pulmonary stuff is definitely associated
so
with a lot of
important.
complications,
Yeah, so
including death.
You can track that quite easily. the
Yes,
pulmonary.
it's easy to kind of catch that. Like, look, this is what we intervened. They were on, CPAP or pressure support or whatever. Now we're off. Now we're extubated. Now we're so
Exactly
It
right,
can be
yeah.
done vented as well. You don't have to be. Ideally not, but there are folks for whom the risk benefit
Right,
makes sense.
right.
You've got lots and lots of rib fractures. You're just not going to be extubatable.
Right,
You know.
right.
So we do this.
Now there was talks of rib fracture plating coming here.
Yes,
Would this
and
be
they
in
have plating. We've
conjunction?
done them.
Oh, we've done
I've
it.
Done a
done, I
couple.
think, 2.
Okay,
some
great.
places have been
So
done,
would
yeah.
this be in
So
conjunction
this
with that?
Could be in conjunction
Okay,
with that. This
okay.
could be an ideal thing to do before that.
Yes, okay.
Really help cut their opioid requirements
Right
and then
on.
stabilize, because it makes sense. Like, this isn't curing anything.
Right.
It's shutting down the pain sensation, but stopping excess movement, particularly with comminuted fractures where they've got fractures in 2 places or flail chests
Right.
and things. Yeah. And so in the case of this, I don't have to treat both sides. I can just go as far posterior as possible, one rib level where the fracture is, and then above and below, whatever
Okay.
that works out to.
And how many treatments, Scott, are they going to need? Do you
Usually just
one
one,
and done?
one and done, multiple levels, that 1 hour session, and then say you would expect 2 to 3 months. There may be a group of people for whom we need to retreat. That's
Right.
possible. Like if incomplete treatment, they'll continue to have pain or maybe a change in their pain. So we want to make sure we're getting, and that's kind of why it's not a broad rollout, why everyone's not doing this. There's a little bit of a skill set. There's a little bit with the ultrasound. There's the cost. Those are the main barriers to doing this.
Right.
So, but I think it's
Sounds
I think
awesome.
it's gonna be cool to have
Yeah.
this
I think
here.
it sounds
I
so
like
cool.
it.
I know if I had knee surgery, this is what
this
I
is
want.
what
Oh,
I
yeah.
want.
You know,
Wow,
do
yeah.
this before my knee surgery.
Please. Yeah.
Yeah. So I've been at workshops in the States with folks that
Okay.
do a lot of this. Orthopods do it in their offices.
Oh, wow.
Physiatrists will do this. The guy on the coast, he's an anesthesiologist who works with a physical medicine and rehab guy, and they put together this program. They treat adults, children. It's
Wow.
amazing.
Wow.
And seeing the difference they're making in people's lives. Post-stroke, where you're able to get the hand
Ah, that's crazy.
down and
I can't
open.
imagine.
They can do some
Yeah.
physio. I mean, it's changing people's
Yeah,
lives.
right on.
Yeah. So
Can this be used for chronic pain patients? Like
It-
the patients that go for rhizotomies
yeah,
and
it
blocks?
depends. So they've come up with a longer needle. So there is some ability to treat near the spine, medial branch blocks and things. The downside with some chronic pain is it becomes centralized. So now it's at the level of the spinal cord.
Oh,
So
okay.
treating peripherally may not help. There's
Right.
acute on chronic pain too, where someone with chronic pain now gets a fracture or something, and we see those folks.
Yeah.
Treating the acute process is still doable, but some types of chronic pain become central sensitization. It becomes centralized now. There are processes in the spinal cord that are perpetuating it, and even if people, they cut off their leg and they still have phantom leg pain. Like, it's clearly, it's not there anymore. It's now moved to the brain and or spinal cord as the process that's maintaining it. So that would be a kind of a no. But yes, people are treating, just like they're doing rhizotomies, they'll do a version of that with cryo.
Okay.
When you do rhizotomies, you're using heat, electricity and heat, and you're burning things. And this was a great analogy, which was that if you put something in the freezer and you take it out and thaw it, it's pretty close to the same. It might have a little freezer burn, but it's pretty much steak. It's still steak. Once you cook a steak, it's not the same.
That's right.
So when you burn something, it's permanent. And so when they do rhizotomies, even those folks come back for more treatment, the nerve buds and it tries to regrow new things, but it's never the same. And so it can actually be very hard to, multiple rhizotomies are less successful because the nerve now, instead of growing back normally like this, it often kind of like a shrub that you've pruned.
Interesting.
Yeah, didn't know that.
So
it's kind of like the difference between like a second degree burn, second and third degree burn.
yeah, there's reversibility here versus like permanent scarring. So it may turn out down the road that this is a good way to go, although it's not a permanent fix for those folks. So they
Would
need
have to
something
keep
else.
coming back.
Yeah,
But
they keep coming back, or they do something else.
But they keep coming back.
Yeah.
But
They do anyway.
they keep coming back.
Yeah,
for
this may not last
rhizotomy.
as long as burning the nerve. This is to be determined. People are
Right.
figuring this out. I won't be doing that because that's still done with fluoro.
Yeah.
I'm going to really concentrate on those folks that I know I can help.
Yeah.
But by bringing the technology here, that allows other people to come spend time with me. Now it's in house. Potentially, we can order more things. The chronic pain guys can be experimenting with this. If we have a physiatrist there's a neurologist who does movement disorders. Robin Bessemer. I just got a little email saying he's joining us. So I thought,
nice.
There's someone here interested in this. I would support them. There's a lot else that goes into that care pathway in terms of helping folks with spasticity, but it's something we could be doing.
Right.
This is
That sounds awesome.
fantastic.
It sounds awesome.
So
Yeah.
I'm excited.
Yeah.
I think it's really
We're
novel. It's
all
easy to get your head
excited.
Yeah,
around.
this is-
This is an extension of our nerve blocks. It's a way to
Right.
make them last longer.
Yep.
It has some fiddly bits.
I like the decreased narcotic because
That's huge.
it's
drop,
just
drop,
so
right?
huge.
Yep,
It's
yep.
so
Yeah, for sure.
huge if we can decrease narcotics and have people feel like themselves after surgery.
Yeah.
Or rib fractures are huge, like
Yeah.
you said. I mean,
Yep.
you get atelectasis, they
Yep.
get pneumonia, they get
Yeah.
all kinds of
They're not
issues because they're
leaving hospital, or
That's
they're coming
right.
back. Emerge. That's what you don't always know is the ones who come back to emerge, and they wait there for multiple hours, and they get some IV dilaudid, then they go home again, and there's
Yeah.
a few bounce backs where we're like, oh, well, we discharged you. We thought you went home.
Scott,
But
you're
you're not
not
done with
always
us.
here when the rib fractures come.
That's right. So, and the idea for this would be not to do it acutely. So if you come and get your rib fractures, first we get you comfortable.
Yeah.
So we do blocks, we do local,
Yeah.
we do those sorts of things, and then we have a conversation about this. Because you can see it's not just like a yes, no. It's like, okay, well, here's some things you need to know. It's a little fiddly, I need to turn on your side. So it's not something that needs to be done the day they fracture their ribs. You can get them comfortable. So it could be the next day. And my plan is to start with me. But there's no reason McVicker, Olu, anyone who's interested in doing this wants to put some time into it's just a little bit more precision that's needed. And there's cost. We don't want to do this and not have it benefit people and sort of spend money needlessly. So there's that piece. But I think this in the future, 5 years, if you look 5 years ahead of time, we're seeing a lot more of this kind of thing.
Sounds
so
like
let's
it.
bring it here.
Let's bring it here.
So
Good for
it would
you.
always continue to be first line epidural block. And
I
then
think so. I think at least a
that.
single shot block. And
Yep.
most centers that are doing this, they'll even do the single shot block just so patients are more comfortable
Right.
when you turn them.
Right.
Instead of waiting to get them
okay.
on their side. So so you would do a single shot block first, or in the case of the knees, they would get a diagnostic block, that lidocaine.
Right.
So you're like, okay, is that okay? Are we happy with where we're at? Because it's going to be permanent, semi-permanent,
Right.
2 to 3 months.
Right.
Yeah.
Awesome.
Yeah. So I saw some knees that had gone 6 months while I was in Victoria. They were treating people folks that were like, they said I need a knee replacement. And I mean, once you have bone on bone, like again, I'm not changing anything about their knee.
Structurally.
It gives them a window, a band-aid to do something different
Right.
potentially,
Right.
or just wait. I want to go to Mexico this year. I'll do my knee next year.
Right.
Et cetera, et cetera. Like there's a lot of versions of that.
Super exciting.
Yeah, it should
We're
be cool.
excited. It's going to be really
Couldn't do
cool.
this
$700
without help from
is
the
nothing,
foundation.
yeah.
Again, Heidi,
Okay.
one of those, the Chabins have supported our pilot.
Right on.
So we're purchasing. This is mine. I actually bought this.
Oh, wow.
There's 2 more hand pieces coming, and a big box of needles and those cartridges. So
Perfect. And
Yeah.
you've got Corey, I heard, with you. Corey's
yes,
going to be
Corey
your
Pieter's
person.
involved with this project himself directly. Corey's been super helpful, and I think with the knees, we're just going to figure out where that's going to happen. It may happen over in fracture clinic. It may happen in JVM's office. Just it's about where
Right.
we can get everything.
Yeah.
Because what I'll try to do there is schedule a day, 4 or 5.
Oh, okay.
Just do, rather than like onesie twosie. But there's inpatients. We had someone with a scapular fracture that I talked to about. Because again, there are other indications. Shoulders, this can be done. shoulder blade or scapular fractures where it's going to be treated non-operatively, it's going to hurt for months.
Oh, yeah, it is.
So there's a place to do this same sort of treatment near the suprascapular nerve at the back. Foot and ankle stuff.
Right.
Yeah.
It's fantastic.
Very interesting.
Yeah, it's really cool.
So
really
when are
cool.
you getting started? Are you still waiting? We're
No.
still
Well, I think
hiring
the equipment should be here. It's been ordered. There's a bit of ethics review that's going on, and the ethics isn't about doing this. It turns out it's about can you call people afterwards and talk to them on the phone. And,
Oh, okay.
partially that's connected to my master's, so therefore, if a university gets involved, suddenly now you have a higher level of scrutiny.
Yeah, yeah.
So that's
okay.
slowed us up a little bit, but we should be treating people probably February or March.
Oh, wow.
I expect.
Yeah. Okay.
There also haven't been a lot of rib fractures. We've had a very
Well,
Yeah.
I know.
so like there's been two.
It's not a bad thing, though.
I know, and I'm like, it's a good problem, but there've been like basically two pretty good candidates, but since December to now, I haven't had the equipment. So,
Okay.
and that's it. Whereas last year, I think we had 3 or 4 a week.
Yeah, it was
You know,
quite a
so I
bit
thought,
more.
okay.
Yeah, quite a bit more.
But in the summertime, maybe.
Yeah, yes, there will be.
And I say the knees. We're going with knees. We'll treat anyone that we can potentially help. Shoulders
Yeah.
and.
I like it. This is cool.
and stuff.
It's so great.
Very cool.
Anybody have any other questions? Or?
Would it be good for things like pelvic fractures?
Hard to. There's one spot where it's been done, and that's for the peng block that we do with hip replacements. People have treated fractures non-operatively doing this, so there is a indication, but it just comes down to where the innervation is and can you get to sensory-only nerves. Pelvis is not an easy one in a lot of places, like the sciatic nerve, big motor nerve, so it's and it's a big nerve, so it's hard to treat. It's much better for smaller nerves where you can get an ice ball to completely surround it. Big nerve, you've got to treat in so many places, and you get incomplete treatment. Again, they have potentially more pain or a different type of pain. So, but yeah, there's a case report. They tried to bring someone to the OR who was pretty sick to fix their hip, a hip fracture, and they abandoned the surgery, resuscitated them, went to ICU, the whole deal, and then had a conversation with them like you're, most M3 in your 90s. There's something else we can do. So they did cryo for a peng block. And I think they had 4 months follow-up. I don't know if they're still alive, but for those 4 months, so they were able to walk on their fractured hip. Like it opened up another avenue of, because we say, oh, hip's fractured, we got to fix it. But okay, well, there may be a group of people that are just too sick to have their hip done.
Right.
Likewise, it's been done for folks who need a hip replacement, just like the knees. Hip replacements will do really well. Folks who get through a hip replacement, they're not like the knees in terms of dissatisfaction. Usually it's been said it's among the most impactful operations we do in terms of patient satisfaction and like return to function. You go back playing golf, you're walking, so there's a little bit of an indication there, but I think knees are a big one where it's like a substantial.
They're so sore.
We do
Painful,
so many knees, and if you do figure 20% of those folks are struggling out in the community.
It's a large number,
Pain and stiffness and
Yeah, it's amazing.
So, is there a path to get somebody enrolled for assessment?
Call me. Yeah.
Oh, okay.
Find me.
Yeah.
I'm around.
If
you have something, and I think, well, we're gonna start off like this.
Yeah, super focused.
JBM and Tyler, I think will be the 2 surgeons from which we'll and then Scott for shoulders. He's already referred me somebody that's kind of a non-operative shoulder candidate. But for the study, we'll start basically with JBM's patients, and then I'll pick up a few. Like Tyler has a person who's supposed to have a knee done, and it's really weird. They had chronic pain after a wrist surgery, and it was like years of chronic regional pain syndrome. So lots of risk factors. So I talked to this person on the phone and I said, hey, you're probably a good candidate for this. There's the risks, there's the benefits, here's what I think. So they're mulling that over, but they'll probably be somebody that will treat prior to surgery.
Awesome.
Is there any autoimmune contraindications?
No. So those cryoglobulinemias and things doesn't seem to have any added risk in terms of the way the nerve heals or that it heals aberrantly. This was approved in Canada in 2013. That's how long we've had it in Canada.
Right on.
It's been in the States for 20 years earlier than that. And there were machines that were doing this. I mean, this has been approved since 2013. There were machines that have been doing it since the 70s.
Okay.
It was a big console thing. That's part of what slowed it down. It was a big
Bulky,
beast to bring to the bedside, and so you weren't taking that to ICU. We were doing it with fluoro or blind, so it was not as there wasn't the potential to be as precise as we can be now.
Right.
One of our colleagues in Vancouver who came here, he did a locum, Mike Jew. He was really a strong proponent of this on the coast, and he's kind of, along with the group in Victoria, has kind of sparked a lot of interest. So he's teaching a workshop. I'm going to help him in Whistler in the end of February.
Right on.
So we're hoping to
spread it out.
Spread it out.
Spread it
Yeah.
out.
Yeah.
It's just another thing to do.
Oh yeah,
which
it's wicked.
It's going to benefit our
So
patients so much.
cryoneurolysis. This is iovera. It's the only one that's approved in Canada. There are other ones, and if they ever get approved, we may have the option to look at which is cheaper, which is better.
Right.
This will become cheaper over time. There's no question, but That's the costs today.
700 is nothing, you know.
Yeah, and budgets. I mean, it's not nothing. If it was like under $100, I'd just
Yeah.
be doing this.
Yeah.
The fact that it's 700 kind of falls into that like kind
Right.
of, and you got to order a box of 5, so now you're 3,000 and something. Or
But as a
2,500.
patient,
As a
I know
patient,
we're
yeah.
not there
Oh, yeah,
yet.
you
I
would-
would
you
pay
would
for
pay
that.
for
no
that,
And
matter
as,
yeah.
as I say, for some of the pain groups, that's exactly what they're doing. They're saying, hey, this is what it costs
Yeah.
for a treatment. Maybe you have health insurance. Maybe you can submit it on your taxes as a bill of
Right.
expense kind of thing.
Yeah,
Options. Yep.
Options.
that's awesome.
Very
Scott.
cool, Scott. Yeah.
Thank you
Thank you.
so much
Yeah,
for
for chatting